Today we have the honor of having Dr. Mike Smith here. He joined the faculty in April. From South Carolina.
What part? What part of South Carolina? I moved here from Columbia. I grew up near Greenville.
Yeah.
I went to Furman.
Did you?
Yeah. You went to.
I went to Presbyterian.
Are you a Gamecock fan?
Yeah. I went to grad school at QSC.
Splendid.
Wow. So you've already gotten more participation than I usually get. So Dr. Smith joined our team in the College of Public Health. His main role is working as the director for the Choose Well evaluation, which Dr. Corey and I both have probably, you've probably heard us talk a little bit about that, but it's this huge 6-year evaluation project that we're doing here in the College of Public Health. For those of you who know, like NIH funding, it's like a bunch of big R01s put together. We have 5 different major projects with different academic teams, so different primary investigators or leads, and then their co-investigators, their graduate students, their part-time workers. So we have all these people, and then Dr. Smith makes sure we're all doing what we need to do and keeping us organized and working to make sure that we get the project going. He comes to us from South Carolina, as he mentioned, where he spent a decade in public health practice. His last position was as the Deputy Director of the Maternal and Child Health Bureau in the State Health Department, which is called DHEC in South Carolina. And as he mentioned, he got his doctorate at USC. He has he's the number, how many of you guys were analytical when you guys did your sphere? There were more. Analytical. Okay, so Dr. Smith has a bachelor's in math and statistics, master's in biostatistics, and a doctorate of public health in biostatistics. So he likes numbers. So he's going to talk to us about data today. Please contribute and listen carefully, because this is one of the things he's really passionate about. So he primarily works on this project, but we never let anybody get by without teaching, because we love to hear from those who are in our college with a practice background, because that's what the vast majority of you guys are going to do. So without any further ado, I'll let Dr. Smith take over. Thank you.
All right. So again, my name is Mike Smith. As Dr. Betty mentioned, I've been here 8 months or so. And go Gamecocks.
Cricket.
Thank you, Caroline.
Oh, another thing that I did not mention is Dr. Smith is working on collecting a menagerie of animals. So if you ever want to pet something, he probably has it at his house.
All right.
Yeah. We have 2 dogs, a cat, 4 horses, a pony and a donkey, 2 potbelly pigs, and 6 chickens.
Any goats?
So we have no goats. We might get goats one day. Goats are tough on fences. You gotta have really good fences to keep goats in. So if you want eggs, we always have a lot of eggs. So come by my office. I'm in Sam Wilson Hall, across the parking lot.
Brown eggs or white eggs?
They're brown eggs.
Do you ever get green eggs?
You're like, oh.
We had 2 chickens that laid white eggs, and every once in a while we would get a green egg from them. Yeah.
What does that mean?
It's a breed of chicken.
Okay, I'm
Some
sorry.
chickens that like green
Yeah.
and blue and purple.
Sorry, I totally derailed.
No, it's fine. So, I feel like I'm at a little bit of a disadvantage because y'all know a little bit about me and I don't know anything about any of y'all. And I know this is a big group, but if we could go around quickly And just tell me your name, what department you're in, and your favorite flavor of ice cream. And we'll go from there. So let's start at the front.
I'll start with the last. I like vanilla.
Vanilla? Okay.
Yeah, so
Traditional, I like it.
so my name is Sylvester.
So that's
Our science is concentration of MPH.
all right. Excellent. High stats.
Hi, my name is Ifino today, and I'm the community health concentration. And I love vanilla, but I love a little bit of chocolate, but not like
All right.
May, my name is May, and I'm an HSMP. My favorite ice cream is coffee.
Coffee?
Yeah.
All right.
My name is Mike, epidemiology, and I'll eat some mint chip.
All right. Mint chocolate chip.
I am Kofi. Epidemiology concentration. I like strawberry.
Okay.
I'm Natalie, epidemiology and strawberries.
Strawberry.
I'm Kathleen, I'm also Epi, and I like peanut butter cup.
Peanut butter cup. I love it.
I'm Lauren, I'm also Epi, and I really like cookie dough.
Cookie dough.
I'm Madison, Epi as well, and I like strawberry. I'm Olivia, I'm community health, and I really like coffee as well.
All right.
I'm Jessica, I'm also community health, and it's a toss-up between mint chocolate chip and chocolate Oreo.
All right.
I'm Bethany, I'm an HSMP concentration, and my favorite flavor is Moose Tracks.
I hear you.
I'm Jessie, I'm also HSMP, and I'm also Miss Tracks. I'm Mallory, I'm HSMP, and chocolate chip cookie dough.
Awesome.
Adekunle, HSMP, sweet flavor.
Sweet flavor. Okay. So you don't like sugar-free ice cream.
I love that flavor.
Keto, MP, and I like strawberry.
I'm Rena, I'm community health, and I like birthday cake.
Yeah. Okay.
I'm Kelly, I'm in biostats, and I like cookies and cream.
Awesome.
I'm Nene, I'm in community behavioral health, and I like vanilla.
All right. And you're a nutritionist, so you don't ever eat vanilla ice.
I'm Michelle, I'm an epi, and I like peanut butter cup.
Peanut butter cup.
I'm Forum, I'm HSMP, and I like cookies and cream.
Cookies and cream.
I'm Jessica, I'm an Epi, and I like cookie dough ice cream.
Cookie dough. All right.
I'm Dawn, I'm in HSMP, and then I like strawberry.
I'm Adrian, I am newly HSCP, and I am all about the cake batter.
Yeah. Okay.
I'm Bridget, I'm epidemiology, and I like cookie dough.
Cookie dough.
I'm Leanne in community health, and I like chocolate chip ice cream.
Chocolate chip. Okay.
I'm Bindu, I'm an Epi, and I like chocolate flavor.
Chocolate. All right.
I'm Manu, I'm an HSMP, and I like vanilla.
Vanilla. Okay.
Victoria, I'm in community health, and I love chocolate.
Chocolate.
I'm Fasil Nubavisayo, epidemiology. I don't have any preference, I can take anything.
So you like sweet ice cream also?
I'm Griffin, I'm an Epi. I like mint chocolate chip, though I prefer gelato.
Oh, okay. Gelato for ice cream. Do we have any custard fans?
I eat frozen yogurt.
Yeah, frozen yogurt.
Yeah, Epi and I like vanilla.
Vanilla?
Soda, I'm Epi, I like caramel chocolate.
Okay.
Yeah, I'm Andy, in HSMP, I like vanilla, chocolate and strawberry.
Oh yeah. Neapolitan.
Blue Oceans, I'm in biostatistics, and I like banana flavor.
Vanilla. Okay.
I'm Erin, I'm an HSMP, and I like coffee.
Coffee. All right.
Mohammed, I'm Epi, and I like vanilla and strawberry.
Vanilla and strawberry.
Kelly, community health, and I like coffee.
All right. That's specific. I like it. Amy?
I'm Amy. I am also HSMP, and mine would have to be gelato as well.
Dr. Beatty?
Well, I don't eat ice cream.
I think it would be a salted caramel.
All right. So again, I'm Mike, and so my training is in biostats. I worked for a long time as an epidemiologist, and now I'm in HSMP, right? So you're not locked in, all right? Even after you graduate. And my favorite flavor is Moose Tracks. I love Moose Tracks ice cream. Thank you. That was very interesting to me. I appreciate it.
I thought you were gonna give ice cream at the end of this, like.
What's that?
Correlation to this.
No, but don't worry, the ice cream thing will come back. I love ice cream.
You gotta hope so.
Right after lunch too. All right. So we're talking about public health communication today, and so really what I'm kind of getting at there, and can everybody hear me okay? It's loud enough in the back? All right. So, I mean, really what I'm talking about is using data and communicating data effectively. And so we'll kind of go all around that, but I'm happy to discuss it. If you have questions, if you have comments, if you have experiences, whatever, we can stop and talk about it. So just by way of overview, quickly, we're going to talk a little bit about surveillance, about data sources, about informatics and health information systems, and I'll go through some examples that I've worked on of using data to impact things in the real world, and then try to finish strong with a big finish. So that sounds really exciting, right?
Yes.
Maybe to some of the Epi and Biostats folks, that sounds pretty good. And there's a good many Epi and Biostats folks in here. Didn't think it'd be that many. But for the rest of you that aren't Epi and Biostats folks, maybe that doesn't sound quite as thrilling. So I hope to make it a bit interesting. So we're really talking about data, and if you're not Epi or Biostat, if you're really interested in influencing individual behavior through health education, or if you're interested in influencing policy, or if you're interested in influencing health programs or health service delivery, right? I mean, why do you care about data? I'm asking, that's a question. I mean, is it just for somebody else to do? Or, yeah, why do you care about it?
Data can inform intervention policies, programs.
Yeah, so if you're interested in policies, programs, interventions, delivery, education, right, you want those programs, those systems to be as good as you can make them, right, if you're working on them, and if that's your job. For example, if you're running a health program where you have nurses that are going and doing home visits at people's houses, right, to do health checkups and things like that, right? You want that program to be as good as you can make it. And so how do you improve a program, right? I mean, you just talked about quality improvement.
Benchmark.
Yeah. You gotta assess and monitor and track data, right? So if you want to be good at doing the things that you really care about, if what you really care about isn't data, well, you need to know a little something about data and a little something about how to use data effectively. So surveillance and information systems are all about collecting data, managing and using data, but we already talked about that. Why do we even care? Well, we care because data is really important for the things that we really do care about. So we got to have data. Agree?
Yeah.
Yeah. All right. So this is two people walking through the woods. There's a big lightning crash. Boom, crack, thunder. One person says to the other, "Whoa, we should get inside." The other person says, "It's okay. Lightning only kills about 45 Americans a year, so our chances of dying are only 1 in 7 million. Let's go on." And then at the bottom it says, "The annual death rate among people who know that statistic is 1 in 6. So this is called conditional risk, right? So if you're outside in a lightning storm and you seek shelter and go inside, right, your chances of dying might be something like 1 in 7 million. If you're outside swinging golf clubs or walking through the woods or climbing a tree or whatever it is that college kids like to do in their free time, climb trees, I think, right? Isn't that what most, okay. Then your chances of dying are not 1 in 7 million, right? There's something much different, given that you've decided to stay outside in a lightning storm. So, I mean, I show this and I say this to say that data is important. Data is good, and you need to use data to improve the things that you really care about. But even data used the wrong way, or data that's not collected well, or data that is collected well, but you're not using it for what it was collected for, right? It's not using bad data or using data incorrectly is not innocuous, right? The best case scenario is that it's completely useless, right? The worst case scenario is that it's dangerous, right? It's harmful to the program that you want to improve, right? So you're trying to decide where you should send your nurses, and you're basing it on bad data, and you're sending them to the wrong places, right? You're sending them to places where they don't need to be as much, so your results aren't as good, right? And you know, when your evaluation comes back, your program's ineffective and you don't continue to get funded. You know, worse yet, you haven't provided the services to help the people that you're trying to help, right? So it's not just having data, right? It's having good data, and it's knowing how the data was collected, and it's using the data the right way. Make sense? Okay. So public health surveillance is the ongoing systematic collection, analysis, interpretation of health-related data, essential to planning, implementation, and evaluation of public health practice, right? So planning, implementation, and evaluation of public health practice. So surveillance is using data for the stuff we care about, right? So whether you're on the epi-biostat side, or if you're on the health education or health services side, or health policy side, right? It's a continuum. Right, so it's using data to inform things that you care about, and doing that in a way that's responsible, doing that in a way that's accurate, doing that in a way that's meaningful. And so this is from the World Health Organization Field Epidemiology Manual. I put that abbreviation up there, and some people don't know what it is, and they say, who? And I say, yeah, who? And they say, who? And we just get stuck in an infinite loop. Terrible, so I have to say World Health Organization. So we got to have data, right? And we got to have something that we care about that we're applying it to. And you're usually working in a team, right? It's not just usually one person working on all aspects of everything, but you've got to have some understanding. And sometimes, say you're in health education, or you're in health services research, or whatever, you're trying to put together a grant application. You don't have your team yet, right? And you're trying to get something funded because you have something that you care about, and you see a need, right? And you don't have your team yet, so you got to put together good enough data in a grant application or in a sales pitch to go somewhere and get funded to build your team, right? You don't have to know how to run marginal structural models, right? But you got to know how to get some data. To make your case. So that's kind of what I'm going to be talking about today, like where you can get some of that data, how to access it. So let's talk about some different types of data that's used for health projects and health research, right? We have clinical data, right? So stuff like when you go to the doctor, stuff that's in your medical record, right? So we have paper medical records, electronic medical records, and electronic health records. Have y'all talked about the difference between electronic medical records and electronic health records?
No.
No? Does anybody know what the difference is between an EMR and an EHR?
Electronic health records are comprehensive and it spans over time, whereas electronic medical record is like subject to one facility for one patient.
Yeah, so like if you think about paper records, you're exactly right. If you think about paper records, right, you've got the charts and they're in a file, right? An electronic medical record is kind of like a scanned version of those paper medical records, right? So it's electronic in that it's on a system somewhere, but it's really just kind of another way to file those records. An electronic health record is a system where the doctor's office is transmitting information from your doctor's visits to the pharmacy, right? And it's transmitting information from your, say, your cardiology visit back to your primary healthcare provider, right? And it's giving you a patient portal that you can log into, and you can see and you can kind of keep up with your health records yourself. So that the electronic health record is much more comprehensive, whereas an electronic medical record is really just kind of a digitized version of those paper records. So, questions about that? Is that clear? Okay. Okay. So clinical data. What are clinical data collected for?
Morbidity and mortality rates, maybe?
Yeah, I mean they get used for morbidity and mortality rates. But what do you think?
Would it be for doctors so they can know how to treat patients based on previous records?
Yeah, so really clinical records are about when you come back into the doctor, they can look back at your records, or when you go to a new doctor and they have access to your EHR, they can look back at your old records, right? So it's not really collected for research purposes, it's collected for clinical care purposes, right? To make sure that your doctors are giving you the best care that they can, or your nurse practitioners or whoever you're seeing. Right, so that's the focus of these clinical record systems is really around provider-patient interaction and care. Right, so it's important to know what the data is collected for, because if you're using clinical record data, there might be certain inherent limitations because that data wasn't collected for research, right? It's collected for this doctor-patient care exchange. All right, so vital records. So birth certificates, death certificates, fetal death reports. So those are stillbirths, induced terminations of pregnancy. Those are abortions. And those all get recorded with the state. Marriages, divorces. These are all vital records that are collected by the state health department. What are these data collected for? Are they collected for health research purposes?
Research for planning.
So, I mean, some of them are collected more for health research purposes than others, but generally, yeah, I mean, they're for record keeping and documentation. They're legal documents, right? The marriage data, the divorce data, the birth data, right? You got to have a birth certificate in order to get a social security number, in order to get all this stuff that you need when somebody is born here in the U.S. So the main thing that vital records data are for is documentation, record keeping, legal documents, right? So some of them, especially birth certificate, death certificate, these fetal death reports, they have been developed with some health research thought behind it. But really, the primary reason they're collected is not for health research, although they get used a lot, and I use these a lot. But so, does anybody know how much information is on, say, a birth certificate? Good. It's this, right? So this is the birth certificate in the state of South Carolina, and so I want to say that. The power to collect vital records rests with the states, right? So the U.S. federal government can't say, this is what has to be on your birth certificate, Tennessee, right? Tennessee gets to say, this is what we want on our birth certificate, right? So if the state of Tennessee said, all I want to know is the mom's name, the baby's name, and the mom's favorite ice cream flavor, right? That's the Tennessee birth certificate. Right, I mean that would be pretty short-sighted, and the National Center for Health Statistics would say, Tennessee, I don't know if you're thinking this through, but Tennessee can do that, right? So everybody across the country recognizes that it's in everyone's best interest to have some standardization. So the National Center for Health Statistics puts out a standard birth certificate and a standard death certificate and a standard fetal death report, and so you have all this kind of baseline. And every state pretty much adopts that. There are little variations, So one of the items here, I know that you can't see any of this, but one of the items here is infections that are present during pregnancy, right? So it's got gonorrhea and hepatitis A and hepatitis C and syphilis and all these conditions. The U.S. standard birth certificate has HIV and AIDS on there, but South Carolina says, that's a little bit more sensitive. We're going to take that off. Right? South Carolina also says, but we want to add a couple of fields for phone numbers. So they put phone numbers on it with, name, address, phone number, whereas other states don't have phone numbers, right? So there are little variations like that, but by and large, it's the same across the country. But you have a lot of information on birth certificates, from mother's education, right? The highest level of education the mother's completed, father's education, mother's race and ethnicity, father's race and ethnicity, information about where they live, right? So you can tell if they live in an urban or a rural area. You've got information about the mother's prenatal care experience. How many prenatal visits did she have? When did she start prenatal care? When was her last prenatal care visit? Does the mom smoke? How much did she smoke in the first trimester? How much did she smoke in the second trimester, third trimester? All right, all this information is on the birth certificate. And then some information for the healthcare facility to fill out, right? What's the mom's due date based on an ultrasound? What are those infections that the mom might have? What are other health factors the mom have? Did she have diabetes before she got pregnant? Does she have gestational diabetes? Did she have hypertension before she got pregnant? Does she have pregnancy-associated hypertension? Has it progressed to preeclampsia? Right, so you have all these different fields, and then you've got stuff about the newborn. Was the baby born by C-section? Was the baby low birth weight? What was the baby's birth weight? What was the baby's 1-minute APGAR score? What about the 5-minute APGAR score? So really, there's a lot of information on these vital records certificates that really gets used a lot for research. Is this stuff that you already know, or is that valuable new information?
Valuable.
Fun facts to know and share. All right, so we talked about vital records data. One thing I want to talk about with vital records data, the death certificate data, there's also a lot of information on there. They can go out to the top 10, top 15 causes of death, right? So, a lot of times it's not just one thing, right? It's had a heart attack, but they also had, so my uncle, when he passed away, he died of a heart attack, but he had diabetes since he was a kid, and he had both of his legs amputated below the knee, and he was in kidney failure, right? So he has several causes of death that are listed on the death certificate there. It also goes into a lot of information, especially if it's a violent death, right? A homicide, a suicide, a police intervention death, something like that, right? There's information on the death certificate about that. The report of fetal death, again, those are stillbirths. There's a lot of information from the birth certificate that we just saw that's on that report of fetal death, and a lot of those cause of death questions from the death certificate are on that report of fetal death also, but it's usually probably 65% of the time the cause of fetal death is unknown because there are so many of them that occur relatively early in pregnancies, and just nobody really knows the cause. So, that's kind of a limitation for using that data, is just there's so many unknown causes of death that it's hard to do much with that cause of death data from fetal deaths. And then the induced termination of pregnancy, the abortion data, it's really, really limited. There's not much collected at all. Like the woman that's getting the abortion, her name and address isn't even collected, right? So you don't even know if she lives in a rural or an urban place. So there's really not much data that's collected at all for those, which is probably a good thing. And then marriages and divorces, those are just really for legal purposes, and there's not much research stuff that gets done with those. The only thing really that I know of that gets done with like marriage and divorce stuff is stuff about name changes, right? Are people more likely or less likely to change their name when they get married? How about when they get divorced? Things like that. That's pretty much all kind of research-y that is done with that data. Okay, so then we have billing data, right? So like Medicaid data or insurance data, hospital discharge data. So almost every state has a hospital discharge database. So every inpatient admission, every emergency room visit, every ambulatory care surgery, like if somebody comes in to get their like an arthroscopic procedure on their knee and then they go home the same day, right? That all gets recorded in hospital discharge data. But just kind of outpatient visits don't generally get recorded in a hospital discharge data set. Some places they do, some places they don't, but generally they don't. But like every inpatient admission, every ER visit does get recorded. So, but again, these are billing data. So what's the primary purpose for collecting these? To get paid, right? I mean, that's what these are all about. These are our claims data is what they're sometimes called. Like this is the data that a doctor's office sends to Medicaid to get reimbursed by Medicaid, or sends to Blue Cross Blue Shield to get reimbursed by Blue Cross Blue Shield, right? And it's claims data because it's what the hospital or the doctor's office or whatever asks for, right? It's not what Medicaid actually pays them. Right, so that's an important distinction if you're using this, if you're using the money data from these claims data sets. It's not what was paid, it's what was billed. Which they're really far apart usually. So, you know, I mean, I talked about hospital discharge data being just for inpatient admissions, but it's for everybody, right? So no matter what your insurance source is, if you go to the hospital and are admitted as an inpatient, your record is going to be in that hospital discharge database. If you're not admitted to the hospital, but you're just going to a hospital clinic to get a physical or whatever, and it's paid by Medicaid, but that won't be in the hospital discharge data, but it will be in the Medicaid data, right? So Medicaid is not just inpatient admissions, it's everything, right? It's all of your prescriptions, it's all of your doctor's visits, so it's a much, in some ways it's a lot more information because it's all of somebody's clinical care, but in some ways it's a lot less information because it's a smaller segment of the population, right? It's only people that are covered by Medicaid, right? And then the same for any insurance policy. Quick question, do we know the difference between Medicare and Medicaid?
Yes.
Okay. Good, a lot of people don't know the difference.
They better know.
Good, y'all know the difference. Some have said that the president might not know the difference between Medicare and Medicaid. Some people have made that claim, but I didn't say that. But I have heard it said. All right. So these data are all about money, right? So if you're using claims data for health research, right? I mean, what could be some of the limitations there? If you're using billing data for health research.
To make it super technical, some doctors bill incorrectly depending on what they personally want, or versus if an insurance company will actually cover what they really need, so they go like a loophole way to do it.
Yeah, so that's the biggest limitation, and it happens all the time, and sometimes it's not on purpose, right? I mean, it's accidental. For instance, a lot of time it happens like if you're looking at the diagnosis codes in billing data, right? So the ICD codes, ICD-10, ICD-9, okay. So if you're looking at the ICD codes, those aren't tracked as closely by the Centers for Medicare and Medicaid Services. So if you're getting blood work done for diabetes, right, whether you've been diagnosed or not, you might get a diabetes ICD code in the billing data, just because that's how it gets done a lot of times. They're not going to use a procedure code, right? They're not going to use a procedure code saying that they, did some minor surgery or something like that if they haven't really done it. But those diagnosis codes get kind of misapplied all the time. So if you're trying to use billing data to say, what's the prevalence of diabetes in Tennessee, you might get a big time overestimate, because every time somebody gets tested for diabetes, half of those are getting a diabetes diagnosis code, just kind of inadvertently. So some of it's because the person who's providing the care, right, the doctor, the nurse, whoever that's putting it in the medical record, says counseled about diabetes, and then the billing person sees, oh, diabetes, and I'll hit the diabetes ICD code, right? That's how it works, and so that makes this billing data kind of messy to use for health research. Does it make sense how that can happen? Right, and it's usually not nefarious. They're not usually trying to get away with something. Sometimes they are trying to get away with something, and Medicare and Medicaid have kind of data police that monitor the data and look for things that are kind of suspicious and investigate them. But usually it's perfectly innocent, but it results in data that's pretty darn messy, depending on what you want to do with it. And then census data gets used a lot for health research. So what's the purpose of collecting census data? It's just, the big reason is like tax rolls and things like that, right? To make sure you know how many people are in a given area and things of that nature. But it's record keeping primarily. Census data gets used a lot for research. And that's really one of the big population-based data sources for things like sexual orientation, things like that are really important topics, and there's just not a lot of data out there on them. So census data gets used for research a lot, even though it's not really collected for research purposes. And then, there are some things that are collected really primarily for research, right? You have some registry data, right? Tennessee has a cancer registry, Tennessee has a stroke registry, Tennessee has a birth defects registry. So I know y'all have all these slides on D2L, so there are hyperlinks to all these so that you can, so that you can, if you're interested in cancer or birth defects or whatever, well, we might get to look at it. We might not get to look at that. Oh, yeah. Haha. This is the latest report from about a year ago on birth defects in Tennessee. And so you can find out all about, the way the data is collected, right? That's what all this writing is, data sources and limitations, right? The things that we talked about, that's important to know if you're using data, right? To know how it was collected, what the limitations are. Looking at the total births, right? So this is the denominators for the birth defects data. And so you can say, okay, I really want to know about how many heart defects there are, right? So cardiovascular defects here, this rate is 232 per 10,000 live births. So out of about every 10,000 live births, 232 of them or so in Tennessee have a heart defect, right? And so it goes by organ system, central nervous system, 10.9 out of every 10,000 live births. And then say you're interested in anencephaly, right? That's, basically, I mean, it's a horrible thing, but it's where a baby is born with just the brain stem developed, right? So all the top part of your brain is not there. It's really rare. There were 58 instances of that from 2009 to 2013 in Tennessee. So, if you're interested in birth defects, there's 56 pages worth of Tennessee birth defects data here, right? And if you're, say you wanna write a grant or whatever, try to get funding around, folic acid supplementation, right? So folic acid can help prevent some of those central nervous system anomalies like anencephaly and spina bifida, right? So that's something that can really be done about this, and you want to try to get a folic acid program where you're giving folic acid vitamins away to women that are high risk. For example, in the U.S., our grains are fortified with folic acid. So if you're eating, bread that's made in the U.S., you're getting some folic acid in your diet. But a lot of the grocery stores that import food from other countries, right? So like the Mexican grocery stores and the Asian grocery stores, they don't have grains fortified with folic acid. So maybe you want to try to launch a folic acid education and delivery program in Hispanic communities in the Tri-Cities, right? And you need to get funding for that. Well, this might be a good source of information for neural tube defects, is what they're called, in Tennessee, in the Tri-Cities, to try to make a case that we have a need for this kind of program, that there are babies that are having bad outcomes that can be prevented. This is how many are having bad outcomes. This is how many the literature says that we can prevent with folic acid supplementation. All we need is to mobilize something. So give me the money and I'll make it happen. Right? This is the kind of data that you need for something like that. And it's here. Here you go. So the stroke registry, Dr. Quinn here, Megan Quinn runs the Tennessee Stroke Registry. We have some so population-based survey data. BRFSS is the Behavioral Risk Factor Surveillance System. So this happens in every state. BRFSS data does. So Tennessee has state-specific Behavioral Risk Factor Surveillance System data, and you might be asking yourself, what is included in Behavioral Risk Factor Surveillance System? Well, if we open this matrix, if it'll let me, this thing is moving fast. All right, so you probably can't see much of this though. So topics, blood pressure, asthma, alcohol consumption, arthritis, binge drinking, chronic obstructive pulmonary disease, exercise, excess sun exposure, falls, firearm safety, fruits and vegetables, healthcare access, just general health status, healthy days. That's like, out of the last week, how many days would you say you felt really good? HIV/AIDS, immunizations, adequate sleep, influenza, lung cancer, marijuana use, oral health, seatbelt use, reactions to race, right? So that's questions like they ask demographic questions like your race, but then they ask questions like, do you feel like you've been discriminated against because of your race in the last week? Do you feel like you've been discriminated against because of your race in the last year? How many times, right? This is one of the only data sources that we have with some of these constructs around racism, right? That are population-based national data around racism. stuff around secondhand smoke, stuff about veterans' health, right? So this is like really broad data that's available from the state health department. And then, let's see, if we go to data and reports here, right, we can select a document, let's say, so there are different types of BRFSS questions, and it goes through them, what each one means here. But let's say, we're interested in core sections, and it'll open up a report with, data from 2016 for Tennessee people who've responded to this behavioral risk factor surveillance system, right? So a lot of information that, you don't have to open SAS, right? You don't have to open SPSS, right? You've got a lot of stuff that's just available here, right? This is 274 pages, right? So it's a reference document, but if you find out, do you have any healthcare coverage, including health insurance, prepaid plans such as HMOs? So if you want to find out in Tennessee, how many people have healthcare coverage? How many men have healthcare coverage? How many non-Hispanic white? How many non-Hispanic Black or African American? How many multiracial? How many that are 65 or over? How many that are 18 to 24 have health insurance? Right, all that information is right here. It's in the behavioral risk factor surveillance system. And it's not that hard to find because somebody gave you a link to it. And then PRAMS is the Pregnancy Risk Assessment Monitoring System. Oh, not edit. Dope. So it's similar information about pregnancy, right? So it's information about women's experiences before, during, shortly after pregnancy, their attitudes, their behaviors, right? Did they, questions about, was their pregnancy planned? How did they feel when they found out that they were pregnant? Were they using birth control when they got pregnant? Are they using birth control now? Because it's asked about 2 or 3 months after the baby's been born. Are they experiencing any postpartum depression symptoms? Did they get a C-section? What was the reason for their C-section? Did they want to schedule it? Did the doctor push it on them? Did they feel like they had a choice in the matter? Questions about physical abuse before, during, and after pregnancy, right? Questions about tobacco and alcohol use before and during pregnancy. Questions about birth outcomes. How is your baby sleeping? Right? Do you put your baby to sleep on their back, or do you put your baby to sleep on their stomach? Do you put your baby to sleep in the bed with you, or do you put your baby to sleep in its own crib? So these are really rich data sets for public health research, but also, just to get information for writing papers or whatever you need it for, or to get information to improve programs that you're working on. And then this YRBS is the Youth Risk Behavior Survey. So this is a survey that's done with high school kids in high schools around the state. So some of the stuff is similar to the BRFSS data, the Behavioral Risk Factor Surveillance System, but it's for high school kids, right? So if you're interested in youth bullying, or if you're interested in wearing a seatbelt, or riding in a vehicle with somebody who's been drinking alcohol, texted or emailed while driving a car or other vehicle, information about being in physical fights, information about being bullied or feeling unsafe at school. Were you ever electronically bullied? Right. So these are big, hot topics. Sexual dating or violence, depression symptoms, suicide attempts, cigarette smoking, electronic cigarettes, alcohol and other drugs. It looks like Tennessee doesn't include those questions, but if you're interested in that in other states, right, there's a lot of alcohol and other drug questions. Sexual behaviors, dietary behaviors, right? If you're working on a health promotion program around sugar sweetened beverages, right? This would be a good source of data about what's going on in high schools around Tennessee, around how many kids are consuming sodas or other sugar sweetened beverages. Physical activity, right? I mean, so there's a lot of good information that's out there. It's not hard to get to or hard to find once you know it's there, right? But there aren't commercials or billboards for YRBS data, right? So you might not know it's there. So are you seeing things here that you think might be of interest to you, of interest to the things that you care about, the things that you want to work on? Yeah. If you had to write a paper about what you care about and you needed to find some data for it, do you think you might be able to find some? Yeah. Okay, good. All right. So I wanted you to just have access to some of these resources because there's a lot out there, like I said, and people have already run the SAS code on it, right? They've already written and run the SAS code and they've put it in a nice data book or something for you. And it's right there and it's pretty user friendly. You have to put a little bit of work into it to figure out what page it's on, right? And to figure out what the limitations of the data are, but you don't have to pay anything for it, right? It's right there online. Okay, so now we know where to get data, right? Then what? We have data, and we have the thing that we care about, right? The policy or program or health education improvement that we care about, right? We need to convert that data into information if we want it to have any hope of having an impact. Yes? Yes. Yeah, because if you drop the BRFSS data book, all 273 pages, on somebody's desk and say, we need to change this program, and the reason is in there, right? You think that that's a good strategy for changing the program that you're interested in, changing the policy that you're interested in? No, you've got to convert that data into information. So public health informatics, that's the process of converting data to information. Right, so systematic approaches of information technology to public health practice, research, and learning. So it's population-based, right? That's what this says, and it's big, right? So big data sets that are not focused on like an individual, they're focused on a population. So public health informatics is the action of turning raw data, which again, as we've talked about, is often collected for other purposes, into information. So you've got data, and you can use informatics to turn it into information, program, policy improvement. Right? But just knowing that informatics is the process of turning data into information, what, I mean, that and $1.50 will get you a bottle of soda. Right? So you need tools to facilitate informatics. Right, so some of that is those data books that we talked about. But there are also health information systems. That's a tool that facilitates health informatics. So these are online data query modules designed to make data available, and they usually try to make it flexible. Some of them are more flexible than others. And there are lots of these out there. Some of them are specific to a specific condition, right? You could have a health information system just about the data in a birth defects registry, right? So that's specific to a certain topic, or you can have some that are really broad. So usually state governments, federal governments put these health information systems together, like CDC Wonder. Have you ever heard of CDC Wonder or use it? You guys love it, I can tell.
No, we don't.
All right.
We don't use it in this class, so
Okay.
I'm guessing Epi.
Well,
All right.
It would be nice to know how to use it.
Yeah.
How to use it?
Yeah.
Yeah, how
So-
to use
Actually,
it.
yeah.
So this is CDC Wonder. You've seen this.
That's all.
Right, okay. So, like I said, a lot of the stuff I've done is maternal and child health stuff. So I'll go to infant mortality. So we're interested in infant mortality, and I want the most recent data I can get. So they have data through 2014. All right, let's do it. And then you have to say, yep, I'm not going to use it for anything that I'm not supposed to use it for.
Sweet.
I won't. Okay, so we got all this stuff. Wow, this is quite a health information system. Cool. Now, what do I do? All right, so I'm looking at infant mortality, and I want it by state, because really I'm interested in Tennessee, I'm interested in the neighboring states of Virginia and North Carolina. And I'm interested in South Carolina because that's where I'm from. Okay, so I'm just interested in 4 states. So I'll go here and I'll say, all right, I'm interested in Tennessee. And see, Tennessee pops up. Now I have to hit the control button and click Virginia. So then Virginia pops up. And I'm also interested in South Carolina. If I don't hit the control button with this finger, right? Oh man, just South Carolina? No, that's not what I want. Control. I want Tennessee. I want Virginia. And then I want North Carolina. Not Dakota. I want North Carolina. And then, like, if I want it for all Hispanic, or I can select which race, ethnicity I want. If I want infant mortality just among women that were married, if I want infant mortality just among teenagers, or just among folks that are considered to be geriatric pregnancies, which is 35 and over, right? I can just highlight all those. But really, right now, I just want all ages because I'm just interested in something really general. I can select by gestational age, right? Am I just interested in infant mortality among preterm births, or am I interested in infant mortality among everybody? What about just low birth weight babies? Do I only want infant mortality for babies that were not born in a hospital? Right? I have all these different options. Do I just want infant mortality for babies that were born via cesarean section? Do I want to select certain causes? Am I only interested in SIDS deaths? Right? So I have lots of different options, and then I can select which years do I want. So I can pick all these years, but do I want it for all those years, or do I want a trend? Maybe I want a trend. So if I want a trend, I might go up here and say group by state and by year. Okay. Yeah, I picked all those years. I want a trend. And I'll say send, and it takes a minute. I picked age of infant death instead of year. But I can go back and year of infant deaths. Sorry. So North Carolina, I see the trend has gone from 8.5 deaths for every 1,000 live births in 2007 to 7.4 deaths, 7.1 deaths for every 1,000 live births in 2014. So it's decreased. Right there, they've all decreased. But South Carolina, it's gone from 8.5 down to 6.4 deaths per 1,000 live births. Tennessee, 8.3 down to 6.9 about. Virginia, 7.3 down to 5.7. So I can see in 2014, Virginia at about 5.7 had the lowest infant mortality rate of these 4 states, followed by South Carolina, Tennessee, and North Carolina. Right, and I've got the trend for all those states. If I wanted that for just preterm babies, right, I would just go back to here, and I would say preterm is anything less than 37 weeks. I can just click on under 20 and highlight down to 34 to 36 weeks. Right, and then I don't even have to scroll all the way down. I can just click send here. And it gives that to me just for preterm babies, right? So the infant mortality rate is a lot higher, 41 deaths per 1,000 live births for preterm babies, right? They're born smaller, they're higher risk, right? That makes sense that infant mortality rate is a lot higher. But, you know, is the difference between the infant mortality rate and the preterm infant mortality rate, is it worse for Tennessee than it is for these other neighboring states, right? We could easily calculate that with what we just pulled and what before and what we have here. Right? We could divide those two numbers and we can say, wow, you know, there's a bigger difference for North Carolina than there is for any of these other states, right? So this is a dynamic data system. We can get it to give us what we want, and actually CDC Wonder is pretty useful in this way once you get used to it a little bit, right? So if you're writing a grant application around folic acid, then you might be interested in all weeks. You might not want it by year. You might want just all those years grouped together because these deaths are going to be pretty rare. But you know, you're really interested in, say, congenital anomalies, right? So you can look for just deaths due to congenital anomalies in these states and what the death rate is per every 1,000 live births, right? So you can get really detailed data. I could do this by race and ethnicity. I could do this just for babies that are born in hospitals. You know, how else can I cut this up? I mean, I can stratify it by, you know, gestational age, by birth weight, by plurality. So if I can look at only twins, I can look at only triplets. Right? I can look at just babies that died within the first 27 days. Or I can look at babies that died within the first 3 months of being born. Right? So there's a lot of data here in CDC, and this is just the infant mortality module. All right, so does this seem a bit better than it did a minute ago?
Yeah. You guys have any questions?
Yeah.
Dr. Smith seems to be a CDC Wonder whiz. Questions about it?
I think it's wonderful.
I noticed that it has like maps and charts and stuff at the top. Are there ways to export the data? I mean, we have to use this tool for another project.
Okay.
So while you're talking.
Yeah. So.
Give Mark example. You got a new topic. You could just go.
So I click on map, right, with what I'd already put in. So this is congenital anomalies, deaths due to congenital anomalies, and it gives me the map, right? I click on chart, and it'll give me the chart for all of them. If I go to results, then it gives me just the table. And I can copy this table let me edit. So I got to clean up the headers, but I mean, I've got the data in there, right? And it's all in a different cell. So I can just delete that, and I can put my own headers in there, right? I can clean it up, but the data's here. Right? So if I need to, you know, run another table and then tell Excel to divide this row by that row to give me a different kind of rate or a ratio, that's not too difficult. Or if I want to just add that map, right, I can just copy the map and put it here too. Does that answer your question?
Yep. You want to also copy the legend so that they know what that.
Yeah. So you want to
just to get full credit on whatever.
Yeah. Beautiful. And I can just say, figure 1. infant mortality rate due to congenital anomalies by state. Right, this was, I think, 2004 through 2014 or something like that.
Can you do that within each state as well? Create these maps?
Within each state?
Yeah.
So you can't, like county maps or something like that. So not from CDC Wonder. So good question. All right, let's proceed. All right. There's also a Tennessee health information system. Health Information Tennessee. So we go here and say, all right, so we have births, deaths, population data, right, that's census, and facilities, if we want information about hospitals or nursing facilities. So we were looking at infant mortality. So let's look at infant mortality within Tennessee, and we want infant mortality rates. Okay, so say we're interested in the rate for Tennessee, but we're really also interested in it for Northeast Tennessee. Or more specifically, if we were interested for Washington County, right? But let's do Northeast Tennessee. Okay, so that's what we're interested in. What do we want? Do we want a bar chart? Well, we were looking at some trends before, so let's do a time trend. And it reset this, so I'll go back to Northeast Tennessee. All right, so we want the time trend in infant mortality for Tennessee and for Northeast Tennessee. And we want to go from 1990 to the most recent that we can, which is 2013. We can select if we want to just restrict to infant mortality by a specific race, by a specific sex. We just want infant mortality among male babies. Or if we want neonatal, which is basically that first 27 days, essentially the first month of life, or if we want post-neonatal, right, from 1 month on. So there are some causes of death, like some of those congenital anomalies, that the death rate is a lot higher in the first month than it is later in the year. But there are other causes of death, like sleep-related deaths, right, that are much more likely to occur beyond the first month, right? So if that's what we're interested in, then we might want post-neonatal death. We can select any of these causes of death that we are interested in, right? If we wanted to do the congenital anomalies again, and you can see that the Tennessee system has much more detail here, right? So we can go congenital malformations of the nervous system, or we can say we're really interested in spina bifida, right? If we're interested in that folic acid example, because spina bifida is one of the conditions that can be prevented by folic acid. So we can look at spina bifida death rates for Northeast Tennessee. And then, or we can just say, give me the 10 leading causes of death for Northeast Tennessee and for Tennessee. And then we submit query. And then we have the infant mortality rate by year from 1990 to 2013 for Tennessee and Northeast Tennessee. And say, wow, that's in a table. I can copy it and paste it into Excel and do what I want with it there. Or I want to see it, I want to see the plot. I don't want to see that, I just want to see the trend line, right? So the blue line is all of Tennessee, the infant mortality rate, and then the green line is Northeast Tennessee. Right, what do you see about this?
Northeast is like all over the place.
Yeah, it's jumping up and down a lot more. Why is that? Yeah, so there are, as you might guess, fewer people in Northeast Tennessee than there are in the state of Tennessee. Does that make sense? Okay, so there are fewer babies that are born in Northeast Tennessee than there are in the state of Tennessee. So that denominator for Northeast Tennessee is a lot smaller for the rate, right? So infant mortality rate is the number of infant deaths divided by the number of live births. That number of live births is a lot smaller, right? Which leads to a less stable rate, right? So it jumps around a lot more. So if the denominator is smaller, just for example, if you have a numerator of 1 and a denominator of 100, right? Your rate is 0.01, right? 1%, right? And going from 1 on the numerator to 2 at the numerator, right, takes you from 1% to 2%, right? So if your denominator is a lot smaller, if your denominator is 10, 1 over 10 is 10%, right, 0.1. If you go from 1 to 2 in the denominator, it goes from 10% to 20%, right? A 1 unit change in the numerator makes a much bigger change in the rate. Right, so that's what we're seeing here. We're seeing that rate jump around a lot more because a 1 unit change in the numerator for the green line makes a much bigger difference than a 1 unit change in the numerator for the blue line, because the denominator for the blue line is a lot bigger. The EPI folks know what I'm talking about. The biostat folks know what I'm talking about. Darn well should, at least. Yeah. So this is Tennessee's health information system. Right, so say I don't want it by year. I just, I want to do county comparisons, right? I can look at all counties in Tennessee, the infant mortality rate, and see which one is the highest. Right, so it gives me ranked. Johnson County is the highest. Truesdale County is the, well, no. See, you've got all these that have unstable data, so that's suppressed because this numerator is so small. 1, 2, 3, right? So they've suppressed this rate, which doesn't make sense because they also give you the denominator. You can just calculate it, right? You can export this to Excel and calculate it. I don't know, that's not really a suppression, but whatever. So you have all these counties ranked by their infant mortality rate. So this is, pretty flexible data that's available for every county in Tennessee. Right? So that's pretty cool, I think. Right? And if you have something that you care about, right, then you have some tools to turn data into information for the subject matter that you care about. Questions about these health information systems? Is this useful? Yeah. All right. Okay. So if you can't find what you need there, or in another health information system that's already kind of giving you what I would call canned data like that, right? You have a queryable system. You can also request individual level data sets, right? So you can request a birth certificate data set, or a PRAMS data set, or a BRFSS data set, and analyze it yourself, right? You have to open SAS or Stata or R, or I guess you could do it in SPSS, but I like to bag on SPSS, so that's my bias. But if you want to know who to contact to get an individual level data set, you can find out right here. And so this is links to all those things, right? Health Information Tennessee, there's the link to it. You can just Google Tennessee Health Statistics, and it'll take you to this page. So information about Tennessee Pregnancy Risk Assessment Monitoring System, Behavior Risk Factor Surveillance System, right? You can get to all that stuff here. These are data sets that are available from this division in the Tennessee Department of Health, right? So vital records and vital statistics, that's your birth certificates, death certificates, fetal deaths, things like that. You can request an individual level BRFSS data set that you can analyze yourself. You can request the hospital discharge data that we talked about earlier, right? You can request that from the Tennessee Department of Health. And then, if you're going to request these things, right, if you want birth certificate data, this is the data release policy. You can access it and read it here. And to submit a data request, this is the button you click. Right? And it's free. It takes a little while, but and then if you, for some of these other data sets, like the birth defects registry data, it gives you a contact person. So you would contact this person and say, I'm interested in this data set. Would you please let me know what steps I should take to submit an application? FEMR is Fetal and Infant Mortality Review. So that's a program where sometimes it's statewide, usually it's for specific areas. For every fetal death or stillbirth and infant death, they review the vital records data, they review medical records data, they have interviews with parents and caregivers to try to get a more complete picture about what happened around this death. So that can be really valuable information if you're interested in that sort of thing. Neonatal abstinence syndrome, right? That's not like abstinence only sex ed. That's neonatal that's withdrawal from usually opioids right after birth. So there's a surveillance system in Tennessee for neonatal abstinence syndrome, tobacco quitline, traumatic brain injury, and then you've got these others too that are more environmental databases, carbon monoxide poisoning data, radon data, HIV and tuberculosis data, right? So all this stuff is available, and if you can't get to it through the Tennessee Health Information System here, you can apply for the big data set. And if you have a really cool idea, so people write their, a thesis or a dissertation on these data sets, right? I mean, it's good stuff, and it's right here. So hopefully this is helpful, having this information all together and having these links all together. Okay, so I want to talk a little bit about data linkages, right? Because we have all these data sets, and some of them can be linked together to make an even more useful data set, right? If you can link birth certificate data to early elementary education data, and people have done this to see if babies that are born low birth weight have better or worse standardized test scores systematically as they go into elementary school, right? These data linkages can be really powerful. So first I want to talk a little bit about clinical data linkages, right? We talked about healthcare records, like in an electronic health record system. So if your data is in an EHR, it seems like it should be pretty easy to link with data that's in another EHR. And within the same health system, right, say within Mountain States, it probably is. Generally, that's fine. That works pretty well. Across healthcare systems, there are things called health information exchanges. And that's what they try to do. They try to be a repository for clinical EHR data across systems. And it's a great idea. And it was pretty important in the Affordable Care Act, right? There's this requirement that that clinical providers and practices had to transition to an EHR or be on the path to a transition to an EHR. And one of the utilities of that is to try to link these records across systems. But there are different EHR vendors and different policies and practices and the way things get done within a clinic that's made this really difficult to pull off. Right? There are health information exchanges in Tennessee, but I'm telling you, they are really, really messy everywhere. So this is something that is big time, still in development right now. Being able to link these clinical records across systems, and it's in most places you really can't do it right now. It's not done well in most places. So what still gets done for example, in South Carolina, the birth defects program was an active surveillance program, and it was done through medical records abstraction. Right? We had a team of nurses that went out to all the hospitals in the state with a laptop and looked in the medical record and put information into our data system. Right? Because we can't link the electronic health records across systems. Right? That would be much more efficient. But even things like, one of the major players in EHRs is a company called Epic, right? Another one is Cerner, right? So say Epic, the default value for does the patient smoke is missing. So if a patient comes in and the doctor doesn't ask them if they smoke, right, it's set for missing. Say in Cerner, the default value is no. So a patient comes in, the doctor doesn't ask them if they smoke, but their medical record says no, right? And you're linking these, and so you're not getting the same thing, right? So even things like that, there's inconsistencies all over the place, even with things like just default values that make it really difficult to get meaningful data from these health information exchanges right now. So if you're interested in healthcare IT kind of stuff, like there's a lot of good work that needs to be done in this area. Because, right now, almost everybody's still using more of kind of a brute force medical records abstraction approach.
Dr. Smith,
Mm-hmm.
is it, because I know these exchanges are fairly expensive.
Mm-hmm.
Is it cheaper to do for the exchanges to be built up with the infrastructure, or is it cheaper to have nurses run around town and do medical abstraction?
For us in South Carolina, it was cheaper to have nurses and go and do medical records abstraction. There are folks who their full-time job every day, all they think about is trying to get these health information exchanges up and running. And if and when they're successful, then buying into that health information exchange might be more cost effective. But right now it's not, because the data quality is not good and not every system in the state is participating. So it's just really incomplete and inconsistent right now. But we also talked about vital records and billing data. And these are much more easily available, right? It's hard to get clinical record data because of laws like HIPAA and the HITECH Act and things like that, right? It's really difficult to get that. Vital records and billing data are much more easily available, and they're much easier to link. Like I talked about birth certificate data, link to Medicaid data, link to early school records, right? That's a pretty powerful data set. If you can have, for a segment of the population, right, just folks that are continuously enrolled in Medicaid, you can have their birth certificate data, you can have every clinical encounter that they've had if they've been continuously enrolled in Medicaid, and you can have their standardized testing data, which it can also be really tough to get because of laws like FERPA, which are good things, but it makes the data really tough to get. But, I mean, that is a ton of information if you're trying to look at the impact of a public health program or a public health intervention or whatever you're interested in. But there are issues with data quality because, as we talked about before, these data aren't primarily collected with health research in mind, right? So you have issues of self-reported variables on the birth certificate, right? For example, mother's education and father's education is self-reported on the birth certificate, right? So, you say, yeah, I've got a law degree and I've got an MD and I'm whatever. I mean, you can check whatever boxes you want. Nobody's looking over your shoulder. They don't know. Also, your pre-pregnancy height and weight is self-reported on the birth certificate. So if anybody would fudge their height or weight, right, it's self-reported. A lot of the prenatal care data, right, it's only as good as the quality of the data in the medical record. So if somebody who's getting prenatal care at a clinic that's not affiliated with the hospital where they deliver, and they have they go into labor unexpectedly, their prenatal care records might not make it to the delivery hospital at the time the birth certificate's done. So it looks like, based on the birth certificate data, that they didn't have any prenatal care, when that's artifact, right? They did have prenatal care, their records just weren't there. So it gets recorded as they had no prenatal care visits. And so if you're looking at what's the impact of prenatal care on low birth weight, that kind of throws things off a good bit, right? That data quality issue. If you have people that, that are recorded as having no prenatal care, and you're saying, wow, people that have no prenatal care, their birth weight is really pretty good. What's going on here? It's a data quality issue, most likely. So there are, with vital records data, there are limitations, and you've got to know those. When we talked about the diagnosis codes and the billing data, right? Diagnosis codes kind of get thrown around all over the place in billing data. But you can do some pretty powerful things with data linkages. So I want to go through one example of a project that we did in South Carolina. And so I'm going to start talking more about examples of using data, trying to turn it into information, and impacting something. And this one really has to do with data linkages. So there was a CDC grant that was basically, hey, does anybody have a good idea for how to estimate the number of people in a state with a rare condition? Right, so a rare condition, like we talked about, say anencephaly that we talked about earlier, right? There aren't many cases of it. We know about how many they are because that's a fatal condition. But what if it's not a fatal condition? What if it's like muscular dystrophy, right? It onsets usually in childhood, and people live a while with it, with different types of muscular dystrophy. Do we know how many people in Tennessee or in a state have muscular dystrophy? There's not really a good way to find that out unless you went into all of the neuromuscular clinics and neurology offices and developmental pediatric offices around the state and abstracted data from medical records, right? And for rare conditions, that's a really inefficient way to do things because you're doing a lot of work looking for data and you're not finding much because they're rare. This is a good question. And so what we said was, all right, well, we're going to try to link in South Carolina all these data sets together. We're going to link birth certificate data, Medicaid data, state health plan data, which is all the state employees, including all the teachers in the state, their insurance data, hospital discharge data, the Department of Disability and Special Needs registry data, and death certificate data. We're going to link all these data sets together and see how many cases of these rare conditions. We were looking at 3 conditions: muscular dystrophy, Fragile X syndrome, and spina bifida, to try to see if we can estimate the right number of cases. And we're also going to go into all of these clinics. We're going to send nurses into all these clinics and abstract data out of medical records. And that's going to be the gold standard, right? So in a few counties, in 5 counties around the state, we're going to know for sure how many people have muscular dystrophy, Fragile X syndrome, and spina bifida, because we're going to ask all the doctor's offices, right? That's a really work-intensive, expensive way to do it. So we're going to do it for a little area, and then we're going to link all these data sets together and see if we can come up with a way to systematically estimate this gold standard. Right? So data linkage. And so what we did was we used a process called capture-recapture. It's a statistical technique based on probabilities to try to estimate the right number of people, and it worked pretty well. So the issue was, like I said before, every time somebody came in and had a muscle biopsy to test them for muscular dystrophy, they got a muscular dystrophy diagnosis code, right? So there were way more muscular dystrophy diagnosis codes than there were cases of muscular dystrophy. So we had to figure out a way to cut that down, and there's not a way to cut it down the exact right amount, so you cut it down to something you know is too few, right? That's really an underestimate, and then you can do this capture-recapture method with something that you know is an underestimate to try to get to about the right number, and it does pretty well. But then when we link those to the to the clinical records that we had collected, right, from abstracting medical records, they're often the ones that we had weren't the right people. Right? So we could get the right number, but they weren't necessarily the right people, which is not unexpected, right? Capture recapture isn't trying to get the right people, it's trying to get the right number. So it worked pretty well to do what it was supposed to do, but they weren't the right people. Well, we could also come up with a good way to get the right people using a different approach, but it wasn't all of them, right? So it wasn't the right number. So can we estimate the number of people in a state that have a rare condition with linked medical records? The answer is kinda, right? We can give you the right number or people that really have it, but we can't give you both. You know, so, but which is good depending on what you need it for, right? If you're planning a program to serve people with muscular dystrophy in a 5-county area, maybe all you need is the number of people, right, to plan your budget and things like that. So if all you need is the number of people, you don't have to go into every doctor's office in your area to collect that data, right? If you can link these data sets, you can get a really good estimate. Yeah, so that's what I said. You can do one or the other, but not both. Okay, so we have data, right? We have a health information system, or using SAS or Stata or SPSS or whatever. We can use that to create to apply informatics to create information, and then use that information to impact what we really care about, right? This is the chain that we have now, right? Data, some tool to use the data to perform informatics, to create information, to apply to what we really care about. And that's what we need, right? Okay, so this is two people talking, a guy and a girl. The guy says, I think we should give it another shot. The girl says, we should break up and I can prove it. And she shows him a chart, our relationship, and it's trending down. And he says, huh, maybe you're right. And the girl says, I knew that data would convince you. And he says, no, I just think I can do better than somebody who doesn't label her axes. Right? No labels on her axes. No thank you. So, turning the data into information, right, through some analysis or health information system isn't always quite good enough, right? If it makes sense to us, it doesn't necessarily make sense to everybody else, right? So really what we need is to go from data to some sort of analysis, right? Some application of informatics to information to communication to policy program improvement to impact what we really care about. So this communication piece is something that, in my opinion, gets lost a lot of times in public health programs, especially like epi and biostat programs, right? So being able to communicate complex data or complex research methods in a way that's clear and understandable to a broad audience is a skill that will really set you apart in your career. I guarantee it. Do you agree? Like, it's hard to find people that can understand the data and communicate what it means. So if you can do both of those, you're going to be in good shape, I promise. But that's something that usually gets left out, is that communication, right, of the information that comes from data. And that's what you have to impact policy, right? If you can't go in with, well, we have these really advanced models. We did this capture-recapture analysis. Let me tell you about capture-recapture. It is really cool. So you've got probability theory and all this stuff goes into it. So we think that you should change the way we fund rare conditions programs in the state of Tennessee. What do you think? Sold?
Sure.
No, that's terrible communication. So you've got to be able to make an argument. You've got to be able to make a case. So I'm going to talk through just a few examples of using data to tell a story to try to make an impact. I'll talk about one policy example, one service delivery example, and one program improvement example. Does that sound good?
Should we take a...
Yeah, we can take a break.
Yeah.
I'm on a roll. I'm gonna keep cruising. All right, personal water balance break. Do what you need. Everybody needs a break.
I'm gonna go
Yeah, I didn't know
I just did it and she read it. Oh, well, she might have. Okay, yeah, no, literally, I just think and I was like looking at my grades, and like I went and had it, and I was like, oh, and then I was trying to get to the syllabus to see how much they were, so when I back to my grades, it was like, all right, if you're gonna be back on the grad student, she didn't do the grades. I think she did that on
That was what's frustrating part, is like I went through your review. Yeah, but I mean, that's the other thing.
December 6th. Whoa, yeah,
What I'm saying is I feel like it's
She has not given us any December 6th, tentatively. Tentatively. According to,
I didn't.
Oh, the age class. Yeah, or it was
That was
how,
today. We were there
based on
today.
how you rate these
Tomorrow, maybe you won't be there the same.
Yeah, I was 14.
That's what
I'm either like super young or super old.
I know.
No.
There's only been a couple times where they get
They get it all.
To talk to those
It's like.
the only reason it's way above, I don't want to eat that much.
But social media.
Yeah. Man, over here, Keto was falling asleep. Let me take a picture of her too. Yeah, you were sleeping. Your eyes are closed. And then you woke him up. You always drink everything. I hate you. He hates you. Ruin all the fun. With your graham crackers, you were making a damn. No. Yeah, that was my dad's too. Well, she didn't come back.
That's exactly how he was saying.
I appreciate I will put
Am I saying it right? Am I saying it right? That was so perfect. The first time? Talk to that. I went to Shane in Africa last Friday. Hold on, I wanna yell. Oh, I need a paper towel.
I saw.
Oh no, this is how many points I have. No, I'm not. This is why I'm so No, I'm doing this. If I did an 85, I would just like to have more.
You think you're getting an AM? Not trying to be
I did very well on how? I don't know. The bonus. Not very far, but I don't know. I mean, I just want to myself. I have to light on it.
Yeah, I didn't even expect 100. So I was like, surprised.
I thought I was a little bit expecting. I knew I was going to get an M. I was really mad.
Hey, I kind of wish. Hey,
how I darted?
Your chocolate.
Oh yeah. I'm like, I know I did it. I'm like, all the time.
He got away. He ended up
Okay, let's get back together so we can finish up.
I'm gonna keep on saying. What's Queen?
Wait, no, I've never done it.
Okay. I don't know what.
They don't put the Queen in.
Okay, everybody, let's sit back down.
No, what's I want to Queen is, so it's like Queen.
All right, bring it back. Bring it back. Everybody feeling good?
Super.
All right. All right. I'll get back on a roll. All right. So I want to go through just some examples that I've been involved in of using data to try to tell a story to make an impact on policy, on service delivery, and on program improvement. So I'll talk about the South Carolina Maternal Morbidity Mortality Review Committee, the South Carolina Nurse Family Partnership expansion, the South Carolina Infant Mortality Rate Prevention Plan, or Infant Mortality Prevention Plan. So the first example is around maternal mortality. And so maternal mortality is really rare and almost everywhere. But it's really rare in the United States, so that's a good thing. But it's becoming less rare in the United States, right? So the maternal mortality rate across the country has been increasing. And what's more, it's been increasing in South Carolina, but it's been decreasing in a lot of other developed countries. I mean, increasing in the United States, I said South Carolina, the United States. All of my examples are South Carolina based because that's where I've been working for the past 10 years until recently. So it's increasing in the U.S., decreasing in a lot of other countries. So, you know, to really do much about it, we have to have data, right? To inform what's contributing to this increase in maternal mortality. But as of 2011, only 18 states had an active maternal mortality review board, right? Where they're, I talked a little bit ago about the fetal and infant mortality review. So this is a similar concept. For a maternal death, they look at the vital records data. They look at the medical record data. They talk to doctors. They have people on the committee that are medical examiners, people on the committee that are counselors and social workers and things like that. So they try to take a holistic look and get the coroner's reports and all this information surrounding the maternal death to try to decide, first, was it preventable or not? And second, if it was preventable, what were the leading causes of this death and what could have been done to prevent it? So only 18 states across the country have these maternal mortality review programs and review boards. So why didn't more states have these? Some of the issues have to do with state public health authority. So a lot of states, in every state, the health department has public health authority to access medical records. The Tennessee Department of Health, if there's a reason, like if there's an outbreak or something like that, they can go into medical records and pull that data to try to get to the root of what's going on. A lot of these statutes that give states public health authority, they give authority for epidemic and endemic diseases. And the interpretation is that death is not a disease. So states don't have, a mortality issue is not a reason for a state to be able to access people's medical records because it's not a disease. And that's why wording of policies are really important, right? So you have this kind of accidental carve out. So you have to get a new law passed that gives the state authority, explicit authority, to go into medical records and abstract data for maternal deaths. And then the other issue is that a lot of these maternal deaths are subject to litigation, right? So somebody is suing somebody related to this maternal death. And if you have a group that is collecting a lot of information from a lot of sources about a maternal death, and there's a lawsuit going on over it, members of that group who know a lot about the circumstances of that death and have done a lot of investigation might be called on to testify, or the records might be subpoenaed, right? And so states don't want to be in the position where people that they're pulling onto this review committee are being called on to give testimony in wrongful death cases. People don't want to sign up to be on committees where they know they're going to be pulled in to testify for wrongful death lawsuits. So that presents another legal barrier, right? The data that's collected by the review committees and the review committee members need to be off limits for legal proceedings. So almost everywhere, it requires a new state law to be passed to be able to look at the data to try to find out what policies, procedures, programs should be put in place to try to reduce the risk of maternal mortality. So that's what we decided we need to try to do in South Carolina, was to get a new law passed to allow us to look at this data. So where we started was, we have some data from vital records, birth certificate and death certificate. Let's put together a report that gives all the information about maternal deaths in South Carolina that we can, based on the information that we have, right? So we can say, without doing a full maternal mortality review, and without being given access to the medical records data, and without being able to interview the healthcare providers and interview surviving families and get the coroner's reports and all this other information, this is the best we can do, right? Just what's from birth certificate to death certificate. So that was the starting point. So we put together this report that says, this tells us some stuff about maternal mortality in South Carolina, but we're really not sure where things stand in our state. And then from there, we've identified community and professional champions, right? People whose lives have been impacted by a maternal death that they thought might have been preventable. Doctors and nurses from around the state who have seen maternal deaths among their patients that they thought, if something had gone different, maybe they could have been prevented, right? So, for example, there are women who have had a hemorrhage in a small hospital and bled to death because the providers there didn't know exactly what to do in the event of a major hemorrhage like that because they don't see them very often. The solution is not complex. It's to develop a hemorrhage protocol and hang it on the wall, right, of the operating room so that when that moment happens and a woman is bleeding and nobody can stop it, we don't panic. We say, all right, what is our standard operating procedure? First, we have to make sure we're measuring the amount of blood that this woman is losing. Next, we need to go ahead and get on the phone to a blood supplier to get blood in, so we can go down the list and not have to panic and say, what do I do? What do I do first? What do I do next? Right? So that's the solution, is hang a hemorrhage protocol on the wall. But first we have to decide if that's what more women are dying of. So we have some doctors and nurses from around the state, from the 3 biggest hospitals in the state, that are willing to work with us to try to draft some model legislation, and because the state can't lobby the legislature so it's important to bring folks on board that are willing to approach the legislature and say, this is what we need. I've seen this happen in my clinical practice with my eyes, or this is what we need. This has happened to somebody that close to me that I really care about, right? So identifying champions, drafting model legislation, and then finding legislative sponsors, right? So once we have something that we think will work, right? There have been maternal mortality review laws passed in other states. We can work with those, make it fit the laws in South Carolina that exist around public health authority and access to medical records and things like that, and then have these champions approach legislators who might be interested. We happen to have a legislator in the state who was formerly a practicing OBGYN, right? So that's a natural inroad. One of the doctors that was one of the champions for us went to medical school with that legislator, so she knew him a little bit, and she could get in and talk to him, right? So it's these kind of secondary and tertiary connections that can kind of make things happen from a policy perspective a lot of times. And then after we found a legislator that was willing to introduce the legislation and kind of become the legislative champion for it, get other folks signed on to it, start to talk about it, make a case for it, right? We're providing all the data that they need. The champions are providing all the stories that they need to get people on board. And then it starts to go through the legislative process, right? And we're providing input, and folks are arguing about money at this point, right? How much is this going to cost? Where's that money going to come from? Well, this person told me when we were in the hallway that it wasn't going to cost anything. And why are you telling me that now it's going to cost something? Because this person said it wouldn't cost you anything. Well, that person doesn't really know exactly what it's going to take, because we have to pay somebody to go into the medical records and abstract the data. They've got to travel around the state. We got to have somebody that can enter that data into a data system, somebody that knows how to analyze the data, that can put together these reports for the committee to review. It's not just provide a meeting room for the committee, right? That's not the extent of it. Okay, so we have to argue about money. How much is this going to cost? Why should the state fund it? So it goes on, and the way the legislative process works, you might know pretty much how it works. Do you know, or not really? So the way the legislative process works here is whether it's federal or state, you usually have two houses. For federal, it's two houses of Congress, right? Or in the state house, you have the House of Representatives and the Senate, right? No matter what, you have these two deliberative bodies, right? So it gets introduced in, say, the House of Representatives. This bill does, right? So we've drafted this model legislation. We've got a legislator to introduce this bill, and he introduces it in the House, and it goes to a subcommittee, right? It goes to the medical subcommittee, right? And they talk about it, and if they all agree with it, they pass it out of the subcommittee, they vote on it, and it goes to the full committee, right? The full committee looks at medical, municipal affairs, and military stuff. I don't know why they put those together, other than they wanted to call it the 3M committee, because that's what they call it. The 3M committee, medical, military, municipal affairs. So it goes to the 3M committee, and they vote on it, right? And if it passes that vote, then it goes to the full House, right? It gets read 3 times before the full House, and then they vote on it, right? And every time it gets read, it's open for debate. People can talk about it. For something that's not super controversial, right? If the committee approves it, then the full House isn't going to go against it because they expect that diligence to have been done at the committee level. So that was the case for this. The full House passes it, and then it crosses over to the Senate, right? So now it's past the House, and it goes to the subcommittee level in the Senate, and they've got to vote on it and approve it. And then to the committee level in the Senate, they've got to vote on it and approve it. The full Senate reads it 3 times, has debate, whatever. They can call in people, ask them questions, make them answer questions, and then they vote on it. Now, if it passes and it's the same as the House version, then it goes to the governor's desk to be signed into law. And the governor can either sign it into law or veto it. Right? If it gets vetoed, then it has to be overturned by a 2/3 majority in the House and the Senate. But if it doesn't get vetoed, it's signed into law. So that's if it goes smoothly, right? Subcommittee, committee, full House, subcommittee, committee, full Senate, signed into law. That's if it goes smoothly. So what usually happens, and what happens here, the House passes it, it goes to the Senate, the subcommittee or the committee, they want to change something in the bill. So it gets changed in the Senate committee, and then it goes to the full Senate, they vote on it and pass it. And then you have a bill from the House and a bill from the Senate that aren't the same, right? So they put together what's called a conference committee that has 3 House members and 3 senators, and they debate it, and they can either, like if it's, say, an issue of funding, right? The House said that they would fund it at $200,000 a year. The Senate said they would fund it at $100,000 a year. And so it's not exactly the same. They can either, this conference committee, 3 House members, 3 senators, can either take the House version, take the Senate version, or take something in the middle, right? They can't take it up to $300,000 because that's outside those bounds. They can't take it down to 0, right? It's got to be between $100,000 and $200,000, right? So the conference committee comes up with a compromise, and whatever that compromise is goes to the governor's desk to sign into law. So that's a long, drawn-out process, right? So state and federal policy moves slow. For good reason, right? Because you have to, ideally, you have to have the data, you have to make a case, you have to convince people that this is the right thing to do. So we monitored the legislative progress, we provided input, right? They had the committee meetings, we were there to answer any questions that they had and argued about money. And then, the end of the legislative session, they hadn't passed it. So, the bill is going to die, and we'll have to start the whole process over next year. So what they did in 2015 is they put it into a budget proviso. So this is kind of a workaround, right? It couldn't get passed through the House and the Senate all the way through and made into law. So they put a little section in the state budget that gives the state authority to create this maternal mortality review process. And if the budget passes, and they have to pass a budget, and this doesn't get vetoed by the governor, because the governor can veto any line item in the budget, then it's law for 1 year, right? So that's a budget proviso. So we got a budget proviso passed for that year because the bill couldn't work its way through the House and the Senate. But the budget has to work its way through the House and the Senate. So a data collection and a data monitoring program to review maternal deaths for 1 year. I mean, it takes a year to get a system like that set up to do the infrastructure, right? So that's a start, right? But that's not what we need. So it was keep working for another year, right? We have to keep presenting the data. We have to keep telling the stories in a way that's meaningful for another year. And then we had the ability to say, okay, we had this budget proviso for the last year. This is what we did with it, right? We have all these people on board. We had this many meetings. We reviewed this many cases. We collected this much data. These are some preliminary findings. This is why we need to do this more, right? So that gives us more information to communicate, right, to the decision makers. And so we were able to, the next year, in 2016, finally get a law passed to create this maternal mortality review committee. And so it's just starting to collect data, and it's now in statute in the state of South Carolina. So the health department has the authority to go and collect that data from medical records, and the data can't be subpoenaed for a lawsuit, and the people that know about the data can't be subpoenaed for a lawsuit, right? So that's in state law now. So that's one example. That's a state legislative policy example, but that's not the only kind of policy, right? You have program policy, and at the health department, a program like WIC, right, the Women, Infants, and Children program, that touches a lot of people, right? So if you can make improvements to WIC policy, you can really make a big impact on the health of women and children and infants in the state. So it doesn't have to go through that painful legislative process. Or state Medicaid policy, right? Over half of the births in Tennessee are paid for by Medicaid. If you can change state Medicaid policy, if you can show that that gum disease, right, periodontal disease, can be a risk factor for preterm birth, and you can change Medicaid, make a case to the Medicaid agency and change Medicaid policy so that a dental visit is covered by Medicaid during pregnancy, right, that can make a big impact on people's lives and on preterm births potentially. So it doesn't have to be, state or federal legislative policy to be a meaningful, a very impactful policy change. Relating to the work we're doing here around access to contraception in South Carolina, we were able to convince the state Medicaid agency, postpartum birth control is pretty important because a lot of times people think they can't get pregnant right after they had a baby, but they can, right? And pregnancies that are spaced really close together are much higher risk. The birth outcomes are not as good, and the maternal outcomes are not as good if there hasn't been a long enough recovery period, right? So that inter-pregnancy interval is important. So postpartum birth control is important. So what we were seeing in South Carolina is that the conversations about postpartum birth control were happening when the women came in for their 6 week checkup. So 6 weeks after they have the baby, they come to the doctor, and the doctor talks to them about birth control, right? That seems pretty good. The issue that we were seeing was about 50% of the women were canceling that 6 week checkup, Right? I don't know if you've ever had a baby, but when you have a 6-week-old baby at home, you've got a lot of things on your mind and not a lot of sleep to help your brain process the things that you have on your mind. And the health of your baby is more important than your health, usually in your mind at that point. So it's really easy to cancel that 6-week checkup because you feel like I'm doing fine. I don't need to go to the doctor. I'm just trying to hang on here and maintain my sanity. Any parents in the room know that's the case. So about half of women are canceling this postpartum checkup. So right off the top, you're losing the opportunity to have that postpartum birth control conversation with half of the people that deliver live births in the state. So we were able to go to the Medicaid agency and tell that story, right? It's in everybody's best interest. It will save Medicaid money if we have fewer pregnancies close together. So let's allow doctors to give moms birth control before they leave the hospital after they have their baby, right? That was against, that Medicaid would not pay for that before, but we were able to get Medicaid to start paying for that. The first state in the country that did that, and now there's several other states that have followed suit. Not Tennessee yet, but it's on the way. So, and that's that's some of the stuff that we're involved in researching here. That can really have a big impact on not state or federal policy, but Medicaid policy and health insurance companies' policies that can really impact a lot of people. So that was a bonus example. All right, so service delivery example. Nurse Family Partnership is an evidence-based home visitation program where a nurse does home visits with a high-risk woman who it's their first time being pregnant. And a nurse will do home visits throughout the course of her pregnancy, right, to do medical checkups, to give her advice on how to eat healthy, on how to exercise, on how to take care of herself during pregnancy. And then we'll keep doing checkups, home visits with the kid until that kid turns 2 years old. Right, so it's different from some other home visitation models because it goes a lot longer. Right, we're talking about over 2.5 years of investment into a family, and it uses nurses instead of other lay health professionals. So nurses make more money than some other lay health professionals. So it's a really expensive, really intensive program, but in some clinical trials, in some randomized control trials, it's shown really good effectiveness. So there were several sites across South Carolina utilizing state funds for Nurse Family Partnership programs. So we did an evaluation to try to see what the impact of this Nurse Family Partnership program was on some important outcomes. So we linked birth certificate data, Medicaid data, hospital discharge data, and Department of Social Services data, because one of the outcomes we were looking at was founded cases of neglect and abuse. Right? Do you have fewer cases of neglect and abuse among women that participated in Nurse Family Partnership? And we used some cool statistical methods, things I think are cool, propensity score matching. And what we saw is the Nurse Family Partnership participants versus a matched comparison group, right? Significantly less preterm birth, 10% compared to almost 14%. Significantly more breastfeeding initiation, 67% compared to 60%. And maybe some difference in NICU admission, right? 7.7 to almost 10%, right? So some pretty decent outcomes. It looks like participating in this program is making healthier births. So there's another group in the state that knows about Nurse Family Partnership and sees these results and say, how can we expand Nurse Family Partnership? Because it's only available in a few places in the state. How can we make it more broadly available? they find out about this financing structure called social impact bonds. A lot of times it's called pay for success financing. And it's really cool and innovative. So what it is you find some kind of intervention that would save a government agency money. And you get a group of investors together and they sign a contract with the government that says, we're going to pay for this program. We're going to put our money in. And if it saves you money after a certain period of time, 5 or 6 years, if it saves you money, you will return that money to us with interest, right? So we're private investors and we're investing, instead of in the stock market, we're investing in a program that we think is going to do some public good, and we think that we're going to get paid back and we're going to make some money off of this, right? So this program gets expanded, right? The investors have the potential to benefit by making money, right? Getting interest off of their investment. And then the government benefits because it only has to pay for the program if it works. If it doesn't work, the investors are out their money, or some of their money, right? So it's kind of a win-win-win if the conditions are right. So this group in South Carolina called the Institute for Child Success. So well, what if we use this new financing structure to expand nurse-family partnership in South Carolina? So this is something that has been done some in Europe. There have been a couple of social impact bond programs in the US, but they were generally around prison recidivism or juvenile justice recidivism prevention. So people that get out of prison, program to try to keep them from committing crimes and going back into prison. Right? This was the first one for a healthcare program in the world. So pretty innovative. So they had this idea, really innovative. We had this data, right, that shows that this program is effective in South Carolina. And that was kind of a jumping off point. Applied for some funds. Harvard University has this Pay for Success lab. And so got some funding from Harvard to do some additional investigation. And so, where it is now is it's in production, right? It launched in 2016, last year. Nurse-Family Partnership was expanded with funds from a philanthropic group called the Duke Endowment, funds from Blue Cross Blue Shield of South Carolina, funds from Boeing, who makes airplanes, and funds from private funders. They put together between them about $17 million to expand Nurse-Family Partnership in South Carolina, with the agreement with Medicaid that we're going to evaluate this for a period of 6 years, and if it saves money by reducing preterm births, by reducing NICU admissions, by reducing low birth weight births, then you're going to pay us back this $17 million with interest. Right? And the Massachusetts Institute of Technology, MIT, is doing a 5-year randomized control trial to determine if it works. Right? So there's this independent, out-of-state expert group that's going to do the analysis to say, South Carolina Medicaid, yes, this saves you money, or no, it doesn't. Right? And so if Nurse-Family Partnership expansion works and saves Medicaid money, they know it saves them money, and then they can pay for it themselves now and not have to pay back the investors plus interest. Right? They know they can realize all that cost savings. But if it doesn't work, they don't have to pay this $17 million to expand Nurse-Family Partnership. Right? So to me, this is a really cool service delivery example of using data, right? Of having data, right? We're linking data sets. We're using some informatics. We're analyzing it, right? Using statistical methods. We're producing information, and then we're communicating that in a way that's driving some meaningful change in the way Nurse-Family Partnership services are delivered in South Carolina. And then the last example that I want to talk about is infant mortality prevention in South Carolina. So, infant mortality in the United States, it's not the same everywhere, right? The higher rates are in red here. So southern states and some Midwestern states, have higher rates of infant mortality than anywhere else in the country. So if we look at South Carolina, that rate has been decreasing, but it's still higher than the national average. Okay, so that's overall for the state. What if we look at the data by county? Well, how do we look at infant mortality data by county? There, as we saw, we can look in the Health Information Tennessee. There's a similar health information system in South Carolina. We can pull up infant mortality rates by county. We can pull up the number of infant mortality deaths by county. It doesn't take anything fancy, right? It's this health information system that's available everywhere. So we use that data and said, okay, let's plot every county in the state, and across this x-axis, let's plot the number of infant deaths, right? So small counties have fewer because they have fewer births and therefore fewer deaths. Bigger counties have more, right? And then on this y-axis, let's plot the infant mortality rate, right? So you have the number going there, the rate going there, all right? So this is the average number of infant deaths, the median number of infant deaths in a county. In South Carolina, it's 15. This is the median infant mortality rate for a county in South Carolina, 7.65. So counties on this side of this line have less than the average number, right? Counties on this side have less than the average rate. Counties up there have more than the average rate. Counties here have more than the average number. So we have this group of counties with red dots here that have more than the average number and greater than the average rate of infant deaths in the state. Right? So they have a lot and a high rate. Right? So this is what we said. These are the counties with the highest burden of infant mortality in South Carolina. So it's 9 counties. So let's look at them on a map, and let's look at what their infant mortality rates are. So these are the 9 counties, right? So they're kind of clustered together. And in these darker blue counties, the infant mortality rate for this time period was 10.4 deaths per 1,000 live births. And all the other counties put together, it was 6.2 per 1,000 live births, right? So in these 9 counties, 4 more babies out of every 1,000 are dying every year, right? 6.2 to 10.4. So if we want to impact infant mortality in South Carolina, and we have limited resources, where might we want to focus those resources? Those counties, right? You're having 4 more deaths for every 1,000 live births. And then you've got some big counties, right, that have a high number of deaths, but their rate isn't as big, but there are pockets in those big counties. Like this is Greenville County. Who's from Greenville?
Oh.
Greenville, yeah. So this is Greenville County. And so this is where the most infant deaths occur in Greenville County. This is where the highest rate of infant mortality is in Greenville County. So if we're going to target funds within one of the bigger counties, we might not need to target them up here, right? They don't have a high rate. They don't have a high number. But we've got this area in the middle that kind of has the high rate and high number. So we know neighborhoods to target and towns to target within a county. So that's where we want to go, right? So we have these 9 counties, and these are more rural counties, but they're kind of on the bigger rural side, right? Because they have a high number of infant deaths. And in the big counties, we know the neighborhoods that we want to target with our funding. So what do we want to do? Well, the outcome that we're trying to impact is infant mortality, right? The things that cause infant mortality, the leading causes of death are birth defects, low birth weight and prematurity, and risky behaviors and injuries. That's primarily sleep-related deaths. Those are the leading causes of death in South Carolina. After a baby's born low birth weight, there's a lot less you can do to intervene, right? So it's hard to intervene here at this risk factor stage. So if we back up another step, what are the things that impact the risk factors that cause infant mortality in South Carolina? There are things like access to systems of care, right? Do you have insurance? If you're high risk, are you being referred to the right place? Are you getting prenatal care and postpartum care? Is your care coordinated? right? When you go in to deliver, are your prenatal records going with you? If you have to go to a specialist, are you able to keep track of all of your appointments and things like that, right? Your regular prenatal visits and your specialist visits and all those other things. Okay, so access to systems of care, evidence-based patient practices, right? So there are new drugs that are coming on the market that can prevent preterm birth. One of them is called 17P. A lot of doctors don't know about it, a lot of patients don't know about it. So does everybody who needs to know about 17P, can they get it? Can they bill insurance for it, and can they get reimbursed for it, right? Immunizations, group prenatal care models, home visitation models, right? These are evidence-based patient practices. And then health across the lifespan, smoking during pregnancy, physical activity, safe sleep, breastfeeding, things like that, right? These are the things that impact the risk factors that cause infant mortality in South Carolina. And then across the bottom is health equity, right? Because health equity is really important to assure equity, right? So whether it's a rural population, whether it's a low-income population, whether it's a racial ethnic minority, right? To assure that access to systems of care, evidence-based patient practices, and health across the lifespan, that these services are available in an equitable way, and then measure health equity here, right? At the risk factor and the outcome level. So that kind of goes across the bottom. So now we know where we need to focus, and now we know the big buckets that we need to focus on with our investment. So if we have a limited amount of resources, right, now we have a more comprehensive, more effective and efficient statewide plan to address infant mortality in the state of South Carolina. And we have seen, go back to this trend, and what we saw when we were looking at CDC Wonder, right, we've seen infant mortality go from a high of 9.5 deaths per 1,000 live births down to 6.5 in the state. So we have seen a lot of improvement, and South Carolina used to have one of the higher infant mortality rates in the Southeast, and now it has the second lowest infant mortality rate in the Southeast. Right, so these types of using data in a way that is meaningful, right? So you have data, you analyze it, and it doesn't have to be, like, this didn't use SAS or anything at all, right? This is data from, like, you could do this for Tennessee with data in that Health Information Tennessee thing. Just put it in a spreadsheet and make a plot, right? So it's nothing fancy. And then this is, GIS mapping, right? It doesn't have to be on a map. We could look at these counties and say, okay, where are these and what are the rates? Right, and then looking at where things are in the neighborhood. So this isn't statistically very sophisticated, right? We don't have to open SAS to do this. And then this is really knowing the data for the state and knowing the literature around infant mortality to come up with a coordinated plan to try to focus your resources where they're going to be most effective. So those are the three examples I wanted to talk about. A policy example, and then you got a bonus Medicaid policy example, and then a service delivery example, and a program improvement example. Are those examples useful in helping to think about ways to go from, I have this mountain of data and I have this issue that I care about, how do I use the data to impact that issue? Are these examples helpful?
Yes.
Okay. Okay. So this is a Dilbert cartoon. This is, the frustrating part is it takes a long time, right? And a lot of these steps. So this is, a woman walks in and says, Wally, I need the data for my meeting in 3 days. And Wally says, okay, it shouldn't take more than 3 or 4 days to pull it together. And she says, not 3 or 4 days, I need it in 3 days. And he says, okay, 3 days, not counting the weekend and the day I give it to you. He says, that would be 6 days. And Wally says, yeah, 6 or 7 days. And she says, I need it in 3 days, not a week. He says, that's no problem, a week or two at most. And she says, okay, you win. I'll reschedule my meeting for 2 weeks out. And you'll have the data within 2 weeks, right? And he says, yeah, 2 weeks or so. So getting data takes it can take a long time. It can be frustrating, right? If you have to go through an IRB process, right? It can take a long time. It can be frustrating.
Me every day.
What's that?
That's me every day.
Going through IRB? Yeah.
No, just like using excuses.
Oh. But going through IRB processes, it takes a long time, right? It's cumbersome. Communicating that data when people at first don't want to listen, finding the right audience, right? And then finding people that can put leverage on other people to get you a more influential audience. Like that takes time. That takes pushing, right? Applying for grants to try to get funding for the thing that you want to do. Right? You apply for things and don't get funded. You put a lot of work in it and get nothing. Right? It takes time. There are frustrations. And then after you have all of that, actually getting policies changed or implementing new programs, right? That's a lot of work. It takes a lot of time. There are a lot of frustrations. It's not a fast process, and it doesn't have to be a fast process. But it is a really rewarding process to work through. And if you have some things that you go through where it works out, I mean, you can really be making a big difference for a lot of people, right? That's why we're in public health, because we want to make differences at population levels. So it's gonna be hard, but it's not impossible. So don't get discouraged, right? Keep that going from data to using tools to perform informatics, to get information, then communicating that information in a way that's effective to impact the thing you want to impact, right? Policies, programs, procedures, whatever. Okay, big finish.
Yeah.
Does anybody even know what Seinfeld is?
Of course.
Okay, all right, okay. I'm just making sure. I think Seinfeld is great. Okay, so really I want to highlight the importance of mixed methods, right? We have biostats and epi folks, we have health promotion folks, we have health services folks. Data lays the groundwork, but stories change policies, right? So data gets you in the room, but really what sticks with people are quotes, what sticks with people are stories. What sticks with people are people that have been impacted by what you want to change, right? So data opens doors, but stories change policies. And then my advice for making an impact, find something that you're passionate about, something that you care about, a subject matter that you care about, and dig in, right? Get to know the data and the literature, right? Like the infant mortality stuff, that was all data and literature to craft a story. And then figure out how to effectively communicate with decision makers, folks that have money that you're trying to get, whatever, right? So you got to use data and stories to effectively communicate. And the way to communicate, I mean, it's got to be what works best for you, right? I like to use pictures and cartoons and silly things to try to make points. If that doesn't work for you, you can't force it, right? If it works better for you to be really emotionally invested in it and let that emotion come through in your presentation and communication, that works best for you. Take advantage of it. If it works best for you to have a demeanor that is really expert, right? Like I know Dr. Hale's come and spoken to y'all, right? The way he does things is maybe a little bit different than the way I do things. I can't try to do it present the way Dr. Hale does. I can't try to present the way Dr. Beatty does, right? You have to be you and communicate in a way that's effective for you, because trying to model or mimic somebody else isn't going to be as effective as it could be. So again, find something that you're passionate about, dig in and get to know it, and then learn the best way that you can communicate. So that was unsolicited advice. for whatever it's worth. Throw it away if you want to. All right, so I said I was going to talk about surveillance, data sources, informatics, and health information systems, and then go through some examples of data going from data to making an impact in the real world, and then a big finish. So it looks dry on this slide. I hope it wasn't that bad, but I'm done, except for one more cartoon. So this is the person that walks up and he pulls a lever and he gets zapped by a streak of lightning. And he says, "Ah!" and he shakes it off. And he can respond in one of two ways. He can respond like a normal person and say, "I guess I shouldn't do that again." Or he can respond like a scientist and say, "I wonder if that happens every time," and reach for the lever again.
I like how you reenact it. Do it again.
So, a little bit of time left. Any thoughts, questions, constructive criticism would be nice.
You're like conquering the world now.
Good. So, I mean, that's what the ability to use data and the ability to communicate. You can make such a big difference. You really can. It's exciting.
Any questions?
Yeah, questions.
for Dr. Snipes?
So here's my contact information. If you want to talk about your research methods, if you want to talk about anything I've talked about here, anything, I'm happy to talk to any of you. So let me know.
Yes, sir. I just want to know the impact of predictive analytics through the use of big data in public health. Have you?
So
Yeah.
I don't have a lot of experience with predictive analytics. So the question is the impact of predictive analytics using big data in public health. So I'll tell you my understanding, right? So predictive analytics has been around for a long time in economics. And so it's where you have data and you do a regression or something like that, right? And then you have a scope of your data, right? You have, say, if we go back to this trend line for infant mortality, right? We have 2000 to 2014, 2000 to 2014, and that's the scope of our data. And we want to try to use the data that we have to predict what's going to happen in 2020, right? So that's called extrapolation, right? If we want to make inference about what happens within our data, that's called interpolation, right? But extrapolation is outside of our data. And so predictive analytics really deals with extrapolation going outside of our data. It's kind of a new thing with big data in public health, but it's been around for a long time in economics. I mean, there are lots of analysis stuff that kind of starts in economics and then comes over to public health. It's been really hard to accurately do in economics. And I think that the health is probably more variable and more difficult to predict than economics. So I mean, I hope that it is good and it works out well, but I'm not sure, you know? I mean, it's really, I think it would be really, really difficult for public health.
Don't go there or give it a try.
I mean, if it's something that you're interested in, I think you should give it a try and see what the field is like. I don't know a lot about it, so I'm not speaking from a position of a lot of information.
Governmental public health does not like to predict a lot.
No,
stay
yeah.
with
I mean,
what they
we
know.
work within the bounds of our data generally. So I don't have a lot of experience with it. It's a really cool thing, and if you're interested in methods, right, and developing statistical methods, it's a great place to develop new methods or take methods from economics that have never been used in public health before and develop ways to apply them in public health.
I don't know if you've heard of IBM Watson.
Mm-hmm.
Yeah, I've heard a lot of that, but I'm not just sure how to sort of evaluate the impact of it in public health, whether the policy guys will kind of bind into it, like you're saying, if you have the data, you have the evidence, you can change policies. So if I come around and say, okay, based on my prediction, this is what's going to happen in 10 years down the road.
Yeah.
Would you be able to change the policy?
There is a group out of Harvard. The lead researcher is Dr. Bruce Lee, not the. He actually has come and had. I work closely with Healthy Kingsport, and they were really interested in how. So we often talk about it, maybe not as big data, but modeling. So you might find in public health there's some modeling, and so their group has done a lot around modeling data to see if you make certain changes. Say if a new policy happens, or if you can get children to get the recommended exercise, what would that happen in your community? So they have I think he has a book that's like pretty cool, like less textbooky that you can read about modeling. So I know more about modeling happening, which is still predictive.
Yeah, but so that's trying to present like a counterfactual, right? Like if we could pause time and rewind and go back and relive this doing something differently, right? This is what the difference would be.
Yeah.
Right, this is how things would look different right now.
But they do
So
try
it's
to use it to say if you can make these policy implications. And so they might be doing some work in the region, funded through the health systems, because part of the COPA and the merger is to try to be able to capture the impact of it. And the states really want to understand that. And that data is hard to do. Like if you prevent something, that's harder data to find. So modeling can help with that. So there is some cool stuff going on.
Yeah, there's
I'm probably not articulating it because I'm not.
There's cool stuff going on, and I would go back to you asked whether or not you might be able to use it to change policies or something like that.
Because the main problem is the longitudinal study. It takes time.
Yeah.
It's long, and it's possible to come up with some sort of computational process to sort of predict the future rather than waiting that long.
Yeah.
So if I'm gonna make an impact, I don't want to wait till I have few more years to die before I present that solution. So if I'm gonna invest a good number of my time to come up with a process, would that have a meaning? Would I have wasted my maybe 5-10 years of research coming up with that?
So I think it would depend entirely on your ability to communicate your results. But if you could communicate the predictive modeling results in a way that resonates with people and is compelling to people, then I think you could definitely change policies. If you present it in a way that's really dry and kind of inviting criticism, then you probably wouldn't get very far. So I think that it could be like anything else for policy change. It's all about messaging, and you have to sell it. Does that make sense?
Yeah.
That's my opinion. I think it'll be a good avenue to go down if you think you can communicate and message it. Anything else?
So this is why we don't like to just leave our faculty who are research-focused faculty behind closed doors, because they, again, can provide a lot of data and knowledge and experiences. So thank you again, Dr. Smith. And you can find him in Sam Wilson.
Yeah, I'm across the parking lot in Sam Wilson Hall. If you're going out of Lamb Hall, looking at Sam Wilson, the door all the way on the right is where I am. If you need to know where it is, you can ask May or Reggie, because they work over there with me.
Okay, so that is all the lecture we have today, and we don't really have enough time to really get into the final exam review. I'm not worried.
Sorry.
I'm not worried. We'll have plenty of time after Thanksgiving, the one that we're supposed to. But I wanted to present an update to Project 2, not an update to the work you're doing,
project 2 is still project 2. All the